This is a fantastic endodontic case that showcases the power of laser disinfection coupled with the bioceramic apical plug technique for filling up open apices. Hi, I'm David Selouk, specialist in endodontics and clinical director at the Harley Street Academy of Advanced Endodontics. And I'm thrilled to walk you through the technique that we use for this case. This 35-year-old male patient presented asymptomatically, surprisingly. He had a history of trauma as a child, but the area had remained pretty comfortable. The tooth had been filled at the time of the injury, and he hadn't had any treatment since. The only thing he'd noticed was from time to time, he'd experience a swelling in his nose. What we can see here from one of the slices of the CBTC scan is an incomplete root development with a very large canal, and you can see a massive apex. You could literally drive a bus through that. You can see that there's associated significant apical radiolucency sitting above the root, and we can see from this coronal slice, the lesion has actually perforated up into the floor of his nose, explaining the periodic nose swelling. Let me show you what we did here. So here we're making access through the palatal surface. As you can see, once we're through to the canal, it confirms necrosis with an enormous canal space seen here, which is largely empty, no pulp tissue left. Initial irrigation here is carried out with sodium hypochlorite, and we try to assess the working length using the standard way with an apex locator. These cases can be quite challenging when it comes to working length determination because of the wide open apex, and the trick here is to use a larger file size as possible. Okay, so now we're going to start the irrigation process. Now, there is some concern with a wide open apex that we might be extruding some of the irrigants out through into the periapical tissues with a risk of causing a hypochlorite accident. It would be useful to use a kind of more friendly irrigant, something like saline. But how do we get it clean enough? And the answer is through laser disinfected irrigation. Using the laser compensates for the lack of hypochlorite, but achieves an equally good cleaning result. Here we're drying out the canals, and we're going to get ready to pack it with our intracanal medication. Here I'm applying some calcium hydroxide into the tooth, doing it in an incremental fashion using paper points. And what's great about this is it's a dress rehearsal for the next appointment, which is going to be placing the apical plug. So here you can see we're packing it in, putting those paper points down into the canal at pre-measured lengths and filling the residual canal space with some ultracal. At the second visit, the temporary filling is taken out. We verify the lengths and do a final round of cleaning. And now we're going to start to place the MTA plug. Again, this is achieved in a very similar fashion to how we did with the calcium hydroxide, placing increments of bioceramic putty towards the apex and using the paper points to gently tap it down. Paper points are great because it gives you excellent tactile feedback and it prevents you from extruding into the periapical tissues. So we just keep going, keep adding increment by increment until we can get a nice plug of around 4 millimeters. If you're unsure, you can verify this with an X-ray. Once you're happy that the apical portion has been filled adequately, the residual canal space can then be obturated using a bioceramic sealer and warm gutta perca in the usual way. We're just adding the final increments here of the plug. That's looking nice. We can see it's filling up and we're getting a nice apical seal. There we go, so just check that. And we're ready to obturate the residual canal space. There we go, the bioceramic sealer in. Warm GP that's just compacted down against that plug, giving a really good seal. There we go, tidy up and place the final restoration. We're just placing that final restoration just above the CEJ to give an optimal seal and smoothing things off, and we're done. And so you can see here's the final radiograph with a nice apical plug of around 4 millimeters, filling up that irregular canal space, but without sending anything out into the periapical tissues. And then we're going to review for healing in about 6 months. Thank you.